Hello and welcome. Today I'm here to talk about introducing a mobile integrated healthcare program to the San Jacinto Valley, um, and for many reasons. Kind of an overview on slide 2. We find the San Jacinto Valley community will benefit from this program because of its low socioeconomic status and high call volume. A lot of 911 abuse, misuse, or just um, easier access to care, and that's why they decided to call 911 because of the lack of resources around them. This lower economic status, socioeconomic status, is comprised of an 18% poverty rate and median per capita income of $25,000 annually, which we have cited from the Census Bureau most recently. In addition, it is approximated that 38% of its citizens receive health insurance via state-funded program. So essentially, when you provide or combine those statistics above, it is estimated that nearly 50% of the San Jacinto Valley residents have a lack of access or limited access to care that others may not struggle with because they have full health plans and easier health plans that are accessed more readily. And then the MIH program in the community will decrease 911 system abuse. That's our main one of our main goals, and increase access to medical care over time. More of our main goal by providing access to alternate destinations and resources outside the traditional 911 emergency system, which they're used to calling. Goal number 1, kind of starting at point of establishment of communication. The first goal of the MIH program is to establish a nurse navigation triage program when calling 911. So as soon as they call 911, they would get a nurse who is trained in 911 call triaging to figure out what's going on. What kind of resources do they need? Is this emergent? Is it non-emergent? Do they need to get seen in urgent care? Do they need to go see a social worker or at least get set up with an appointment? Do they need to get psychiatric services because local ERs are not going to help psychiatric services? They're going to get referred out. So those are things that we want to essentially flush out of the 911 system, leaving 911 resources, responding to 911 calls, and then get these folks accessed instead of sitting in a hospital ER for hours on end, 72 hours on a hold, and then being cut loose with no services. And then essentially these non-emergencies would be rerouted, like I mentioned, to alternative resources such as mobile field units, psychiatric teams, and community outreach teams. The second goal of the MIH program is to provide access to the alternative destinations and resources after the triage. So now, after they've been triaged, now we're going to dispatch specialty field units, and they can get access to urgent care, psychiatric care, telemedicine, telehealth via like iPads on scene, pharmacies, maybe for prescription refills, depending on if they need help with that with social services, and then substance abuse programs is a big one. People looking to get help, wanting to quit heroin, wanting to quit drinking, but they can't, and they go to ER and they sit there and they try to get them help, try to get placement, but they have lack of, the ability to do so, and maybe even access to some of those programs because they might be full, depending on who they've contracted with, or at the same time, they're just plain off busy because the ER is a busy place, and they get pushed aside to the very last because of the lower priority. Goal number 3 is reduction in 911 abuse. So lastly, the goal of the MIH program would be to decrease the amount of 911 abuse to 911 resources. And often these non-emergent callers just don't simply have access to resources and destinations, so they abuse the ambulance to fill their needs. It's the easy button. This not only increases 911 call volume, but also threatens the safety of first responders in the community because fatigue. There's nothing like running 5 to 6 calls after midnight and trying to stay awake as you go into another 24. A lot of us have been there. And more importantly, this threatens the community safety because of there being no ambulances or resources being available for true 911 emergencies. And these resources are typically tied up on these non-emergent responses. So we want to free those up for true emergencies. Program funding. So this one would be the largest hurdle to overcome for the MIH program, but we'd want a cooperative public-private partnership to be successful, especially with its funding. The contracted private ambulance service is primarily funded by fees for transport. The ambulance service would not be able to completely support the program because they're not eligible to bill or receive for reimbursements for non-transport services. Makes sense. Local government fire departments do have a tax base, and it is limited because of budgetary, depending how much of budget they're given and then how it's divvied up. But they do have access to grant funding, which private ambulances don't. So that might be an avenue of funding that we would explore together in a partnership to move the program along. So kind of the divvy up and sharing of costs that we're looking at is the mixed program. So private ambulance service would cover the cost of staffing, medical supplies, and training of the MIH resources. Not a lot to ask for, but at the same time have the ability to kind of eat some of the costs because of this stuff already being readily available to them most of the time. And then fire departments will cover the cost of 911 call triaging and the folks for that piece and their communication center, because they're the ones that typically dispatch us anyway. And then of course the asset allocation, which we can use via grant funding, and then maintenance and fuel. As far as considerations go, the fire departments would need to consider public safety grant writing, like I mentioned, to offset increased operating costs with communication center and fleet services. All MIH partners would need to consider meeting with local governments to present the program. Huge one, local city councils, board of supervisors for the counties. But in the hopes is that with their buy-in and public buy-in, the MIH partners could receive additional funding outside of the already established budgets. That way it doesn't eat into something else. The additional funding would be considered because the MIH program increases health and wellness resources to all citizens of the community, making us safer. The funding would also support the protection of the 911 emergency system and not allowing it to be continuously overtaxed by abuse. So a projected outcome with goal number 1 would be nurse nav. So accurate 911 call triaging. In first half, we want accurate 911 call triaging as a goal by emergency medical trained dispatchers and the nurses. And then of course, reduction in non-emergent calls being dispatched to emergent resources. So accurate triaging and then appropriate dispersal. And then we want the rerouting of non-emergent calls to resources outside the 911 system. Goal number 2. The projected outcome for the alternative access into medical care and resources is access to alternative facilities and resources outside the traditional delivery of 911 services. Availability of specialized professionals with access to resources outside of what I can offer as a paramedic showing up your house, and the availability of alternative modes of transport to facilities if needed, preventing the tying up of ambulances. This could be specialized mobile field units like a Suburban or a Sprint vehicle. This could be contracting with like Lyft or Uber to get people to other facilities like an urgent care and with a lower cost, and then working with some of their insurance companies to make that happen, or being funded by the MIH program. Or considering using something along the lines of treatment in place, using teledoc and telemedicine, telehealth, to use an iPad to talk to a doctor right then and there when you show up, because you've had certain kind of pain for quite some time. That's not new. We've been dealing with it for years. So what's different? So different point of care access is what we're looking for. Something that an ER can't fix for everybody. And then projected outcome goal number 3 is rerouting of emergent calls to appropriate resources and vice versa with non-emergent calls, otherwise known as call load sharing, right? Load share that call and kick them out of the 911 system. Decrease fatigue and burnout amongst first responders, which leads to increased retention, people that want to stay in our field, people that want to continue working as a paramedic. And then of course, and what this also frees up too, aside from just downtime in mental health, is increasing time for training on skills and job duties. I know as a paramedic for many years, working on a 911 unit, extremely busy. When do I get the time to train? When do I get the time to teach other people about what we're seeing and what we're doing? Because most of the time we're spent running call. And when you run a lot of non-emergent calls, your skills get rusty. So that is our main goal of the MIH program, to increase essentially safety to everybody, decrease the workload, and protect the integrity of the 911 system, and get access to care for those that either can't afford it, they've got decreased benefits, they don't have benefits, and get them out of the ER and get them out of an ambulance when they don't need it. That way they can actually truly get taken care of in ways that we can't handle for them. Thank you for your time.